Okay, so for our final presentation of the day, we're going to have Dr. David Dexter present the complete 2-year outcomes in patients receiving mechanical thrombectomy for deep vein thrombosis in the CLOUT Registry.
Thank you to the program committee for allowing us to present our work, and thank you to all of you for staying to the end of the day on the first day of VIVA. Up here to present the complete 2-year outcomes on patient receiving mechanical thrombectomy for DVT for the CLOUT Registry, and this is a fully enrolled study and fully 2-year outcome. As all of you know, mechanical thrombectomy is a promising treatment option for proximal lower extremity DVT, and long-term outcomes are poorly reported across DVT intervention at baseline, and I'm happy to present for the first time the complete 2-year outcomes of a very large mechanical thrombectomy registry. This is the CLOUT Retriever system. It is a 2-SKU system. On the left-hand side and in the center, you can see a CLOUT Retriever catheter, which comes with a coring element and a long extended collection bag intended to be pulled through clot, cephalad to caudal, to remove clot in large pieces. And on the right-hand side, you can see the CLOUT Retriever sheath with a nitinol funnel approximating the size of your access vessel. And you dock the clot and the CLOUT Retriever within it, at which point you collapse it and remove it from the patient. Clean it, and then re-enter it and pass until clean. This is a mechanical thrombectomy system designed for wall-to-wall contact to remove wall-to-wall thrombus without thrombolytics, irrespective of thrombus age. The CLOUT Registry is a prospective, multi-center, all-comer, single-arm registry. The objective was to evaluate patient outcomes for proximal lower extremity DVT treated just with the CLOUT Retriever system. The primary endpoint was complete or near complete thrombus resolution as adjudged by Marder score, and near complete was defined as greater than 75% improvement in Marder score. This is an independent core lab adjudicated assessment of clot removal, and there was a data monitoring safety board to look for outcomes. We have duplex ultrasound, clinical, and functional outcomes through 2 years. We fully enrolled at 500 patients, with 1 excluded from study who didn't meet criteria, through 43 US sites. It took just over 2 years to enroll the study. There are 340 patients who we know are where they are at 2 years, and we have 296 where we know their position and are alive at 2 years. 11 did not complete the study, so the full data set is an N of 285. As a reminder, we started enrollment in 2018 and ended in 2022, so we ran right through the COVID pandemic, which is a big reason why we had so many lost to follow-ups. In terms of the characteristics of what our patients looked like, the average age was just under 62, with a 50-50 split of male and female. As an all-comer registry, we did allow unilateral and bilateral DVTs, with just under 5% having bilateral DVT. About a quarter of patients had a prior history of DVT. A third had a relative or absolute contraindication to thrombolytic therapy. Approximately 40% had a provoked DVT. In terms of where these DVTs were, we identified 10% or just over 10% as being isolated into the iliac veins and common femoral vein. 68% of patients had clot that extended through the iliac system and down through the femoral and popliteal system, and just over 20% had isolated femoral or popliteal DVT. From a procedural standpoint at 10,000 feet, this is a safe single session procedure. The SAE rate was 0.2%. We were able to do single session therapy in 99.4% of cases. The median blood loss was 40 cc's, and there were no SAEs related to valve damage or vessel damage or acute kidney injury. In terms of the outcomes, we had 91.2% reach our Marder score assessment of complete or near complete thrombus resolution. Our rethrombosis SAE rate at a month was 5%, and our rethrombosis SAE rate at 6 months was 8.4%. When we look at how these patients did from an imaging standpoint, at baseline, we had 27.2% of patients that had non-occlusive clot, or some flow through the target lesion. At 30 days, that number improved after thrombectomy to 85.6%, and after some late recanalization rate complete at 2 years, we have duplex flow in 93.9% of veins. When we look at vessel compressibility at the target vessel segment, there is some compressibility or complete compressibility in 28% of patients at baseline. We have complete compressibility at 30 days of 48.1% and partial at 39.7%. And looking at 2 years, these numbers continue to improve, with 64.5% of patients with complete compressibility of the target vessel segment and some compressibility overall in 96.2% of patients. Looking at post-thrombotic syndrome by Volta score, you can see the Volta scores at baseline on the left side of your screen, with baseline minimal symptoms at 18.1%. At 30 days, we have 71.6% of patients with no evidence of post-thrombotic syndrome and just over 9% with moderate or severe disease. Those numbers not just remain stable, but continue to improve at 6 months, 1 year, and 2 years, with 2 years patients being free of post-thrombotic syndrome of any type at 81.5%, and only 6.5% of patients have moderate to severe disease at 2 years. Looking at pain and swelling on the left-hand side, you can see the NPRS pain score. The pain score at baseline for these patients was a mean of 5. At 30 days, the median dropped from 5 to 0 and remained at 0 from a median standpoint at 2 years. Looking at edema, on the left-hand side of edema is thigh, on the right-hand side of edema is calf. You can see our median circumference of these DVT patients, and you can see a significant improvement of swelling from baseline to 30 days, and that was sustained at 2 years. From a quality of life standpoint, you can see the VCSS, the Venous Clinical Severity Score, started out at a median of 6 at baseline. It improved to a median of 3 at 30 days and further improved to a median of 2.0 at 2 years. Looking at EQ5D as our quality of life metric, you can see that we went from a 0.687 at baseline to a 0.861 and complete resolution median score of 1.0, which is normal function of life at 2 years. In conclusion, the CLOUT Registry demonstrates positive and durable outcomes through 2 years following mechanical thrombectomy with the CLOUT Retriever system. Flow and compressibility in over 90% of treated limbs, a post-thrombotic syndrome incidence of 18.5%, with only 6.5% with moderate or severe post-thrombotic syndrome at completion of study. We showed continued improvements in clinical symptoms and quality of life throughout the trial. At this point, we have single-arm data to show, definitive evidence to come with the Defiance randomized control trial as an ongoing investigation using CLOUT Retriever compared to anticoagulation in a 1-to-1 randomization pattern. This trial could not have been enrolled without the following 43 participating sites and the primary investigators you can see behind me, and I thank all of them for their participation, and again, thank the panel for the opportunity to present.
Thank you, David. Great presentation and good results. Can you tell us, in terms of the adjudication you had, the primary endpoint was clot removal, correct?
Yes.
And was the martyr score self-reported or was it adjudicated?
So the clot was reported in terms of where it was, and the images were evaluated by the core lab, and they did the martyr score calculation for us.
Gotcha. And what about the DUS data that you showed? Was that self-reported or was that adjudicated?
Both. So we sent images to core lab, and we looked at what we saw and sent a report, and the data that I showed you is core lab adjudicated.
Great, thanks.
Those are, fantastic data, something we haven't really encountered in this patient population before. And in your own mind, how much of this is related to improvement? I mean, unquestionably a great device, but we know that we now have a better understanding of anticoagulation, antiplatelets afterwards. Do you think that's a component? And also, you didn't discuss stents, and I'm presuming there were stents used in. Is there any relationship of the outcome to the types or extent of stenting?
Yes, stenting, I'll answer your question sort of backward, Lindsay, and thank you. So stenting is interesting that the stenting rate between this trial and ATTRACT really hasn't changed over the past decade of us doing research into venous thrombosis. So I think most investigators have their own pattern on how they stent and whether they do a delayed stent for someone with compressive disease at 30 to 90 days, whether they stent at index. At least the rates appear to be the same. We do have better stents now than we did during ATTRACT, and that may have some impact on why our results are getting better. Certainly, anticoagulation becomes an interesting question. There was no protocol on how to manage anticoagulation. That was left at the discretion of the investigators. We did collect the anticoagulant used, the dosing used, and the regimen changed throughout time. That's certainly something that we're going to evaluate in subset analysis. And then I think the first question you were sort of hinting at is the open vein hypothesis true? Is there a relationship between more effective clot clearance and getting better results, both short-term and long-term? And that becomes a really, really interesting question, and we're going to try to answer that in analysis of this data. My presumption is it's going to come out to be true just barely with the data sets that we have.
David, great talk and fantastic results. You've shown before that with clot removal, there's less ICU stay, right? We got that last from CLOUT 1 and then CLOUT 2, and the 2-year data is great. Well, what more do we have to prove right now? I mean, it seems like we're having pretty good results with this. Where are we going with this as far as further studies? I mean, we've got fantastic stuff going on right now.
So we have a post-thrombotic syndrome rate in a single-arm trial of 20%. We have post-thrombotic syndrome rates in randomized controlled trials of 40%. For those of you who do superficial disease or ulcer disease or wound management in the audience, it's a public catastrophe, right? I mean, the amount of resources this gobbles up is really, really big. And I don't think that we have agreement amongst those of us in the room, let alone federal payers and private payers, that we should be doing this stuff on a regular basis. I think we have a long way to continue to push to say that we can prevent disease. And I don't know that we've meaningfully done that yet. I think Defiance will be a big part in that. From a chronic standpoint, I think C-Tract will be a big part of that. Yes, this is one tool. It works extraordinarily well. It has great numbers. But I think we have a lot to prove.
Well, I think it just underscores the point, right? We got a room and we kind of get it, but you got to get people who don't believe in it. And I think that's, the point for some of the trainees and other people in the room to understand that there's a different population that needs to understand this too.
Absolutely.
David, excellent talk. I'm curious about, in most of the patients who had excellent thrombus removal, but in the results when you went back and did ultrasound, many or sometimes half of those patients didn't have complete compressibility of the vein. Do you think that was just due to scarring, or was there some other mechanism? And then also, what is the end outcome? Once the vein is scarred significantly and you can and only partially compressible, do you think that has an effect on their prognosis?
So that's the open vein hypothesis I was just mentioning to Lindsay, and I think we're going to figure this out. I think with 282 patients with full ultrasound data sets pre and post, we're going to figure this out. So the best example we have from a tract is that complete compressibility of the common femoral vein as an isolated segment is a great predictor of post-thrombotic syndrome. It's why we did duplex ultrasounds of the entire target vessel to sort of parse that out. I've got my own subset of patients in this trial that I have great data on. We're still looking at this. Partial compressibility is thick-walled vein still that we see post-op. A lot of that does improve with time, with anticoagulation, with thrombotic therapy, with anti-inflammatory therapy. So there is some continuous improvement. There is vessel wall remodeling. It's amazing at 2 years that some of this chronic collagenate material is persistent and some goes away.
Thanks very much for the outstanding presentation. I think with that, we're going to adjourn for the day.